of hard decisions in RA, and we're kicking off with a wonderful panel. And we also had a lot of people, 213 actually, answer a question that just came out, a little short questionnaire this week. So thank you for doing that. So we are going to talk about oral surveillance revisited and maybe have some take homes, and we probably all won't agree. We have a great panel, and I'll be trying to moderate, and hopefully we'll have really lively discussion. So in no particular order, it's the order I see on the screen. We have Jeff Curtis, and Jeff Curtis was invited not just because he's a super smart guy on stats, but because he has done a lot of population administrative database studies and really is quite aware of safety of all the drugs we use in RA and in rheumatology in general. Dr. Jon Giles is here because he's a really smart guy, and because he was a big part of the INTRACT trial that you might remember is what oral surveillance was loosely based on. Sample size calculation kind of similar, event rate a lot different, and we'll probably talk about that, but here for all those exciting reasons in cardiovascular. And Dr. Roy Fleischmann is here because he has been an author on nearly every important JAK study in RA to date, and so we all will have opinions and thoughts. So this is great. I'm not sure, Jeff, John, or Roy, if you want to say anything more formal about yourselves before we get going.
No, you did a great job, Janet.
Okay, good. All right. And throughout this, we really want questions. We've saved and allotted a lot of time at the end for questions. And if not, you're going to hear me talk and our group talk more. So please think of questions all the way along. You can put them in Q&A or in the chat. So what we're going to do now on oral surveillance revisited, we're going to first see what your survey showed. So we're going to bring up a couple sets of slides, and that's just coming up now. And then we're going to talk about oral surveillance, a really quick bottom line. So looking here in the hard decisions in RA, so this survey was it's only like a day old, and we already had 213 respondents. So thank you for responding. And I think we're going to see things that I was not totally familiar with on looking at the diagrams. And we have about half the respondents are from the US. So looking when we get it up, the first slide is telling us 213 people responded. Thank you very much. And about half of them from the US. We're going to just shortly go in a second. We're loading up here to the next slide, and it's asking an overall question, 2 questions, and comparing the overall answers to the US answers. Google Docs is just thinking for a sec here, but what we're finding is that, first of all, there are high similarities in the answers between the respondents who were within the US, half of them, and outside of the US, the other half. So we're going to go to, I don't think these are the right slides, but I'm just going to keep going because I more or less know the results of what they were. So on the pie charts, what we have is looking at the responses. One of the questions was, has oral surveillance changed your prescribing of a JAK inhibitor? And interestingly, about 50% said, yes, it has. And about a quarter to a third said somewhat it has. Yeah, this is what we're looking for. So we'll go to the second slide. So thanks for that. So over 43 countries, but 50% of people from the US. So the first question, did the oral surveillance study prove one drug to be safer? So I think everybody knows this study, and you're attending because you know it and want to get some further insights. But basically, you can see here, US only is the bottom half, and the overall is the top half. So most people said, 53% said TNF inhibitors are safer. Interestingly, about 15%, or 1 in 6 of you, said they're about equal. And another almost 1 in 6 of you said, well, I think neither. And maybe you're talking about statistics, your interpretation of the study, or other things. And nobody really said that TOFA was safer than a TNF. And looking down below that first circle, that's the US answers. And you can see they're almost fully superimposed. When the next question was answered, and thank you again for doing it, the oral surveillance study results apply to your use of, was it TOFA, all JAKs, or whatever? So tofacitinib, both US and the rest, like the entire group, About half said, oh no, I think it applies to tofacitinib. About another third said, I think it applies to all JAKs. That is what the labels have said in EMEA, FDA, Health Canada, etc. And then there's a smattering of people who say TOFA and UPA, so maybe thinking JAK1s, but not thinking, I guess, Barry or Filgo might not have been available in some countries. Before we move on, let's open this up. Does for our panel, does this surprise anyone, or does it confirm what you think is the word on the street?
I think this is perception. This is perception.
And tell me about the perception, because it should be our perception, or it's the majority rules, or?
Well, we're going to talk about it, but I don't think that this should be the perception. But I think that it is a perception.
Okay, good. We're going to talk about your idea in a second, because you're going to present shortly for us a quick overview of oral surveillance. So, okay, perception, whether it should be or not, it's perception. John, any ideas on this? Is this what you would have thought the thing would be cut as, the responses?
Well, I think we don't have the insight of how this dynamically changed after oral surveillance. It'd be nice to know before oral surveillance, which one did you think was safer? And now how did that change with the results? We might have seen the same breakdown even before oral surveillance came out. So I think it's a little unclear how much changed after oral surveillance. Okay.
And do you think did oral surveillance prove one drug to be safer? Do you think 2/3 is about the right answer, or that it's a little bit less or more than you thought?
I think it's about where I would have thought it would come out. I think it also depends on what the person's interpretation of the trial is too. If you're thinking point estimate, you might say, well, it didn't really prove that JAKs were less safe because there was a point estimate that went below 1. And you might say, well, truth lies below in this region as much as it lies above. So it could be people's interpretation of the trial results too.
Yeah. Yeah. And I mean, we probably will break down, hopefully, some questions from the audience about cardiovascular versus cancer too, maybe. Jeff, what is your thinking on this? Is this what the word on the street is that you've heard?
I'm a little surprised by the proportions on the right in this pie chart. So, are we lumping or are we splitting JAK inhibitors? And so, 46% or so of people said, well, these results apply to TOFA, but not necessarily the others. That's, the pink, the orange, and the darker blue. And I guess I'm wondering, if this trial had shown what it was expected to show, which is non-inferiority, would people have made that same statement? If this showed that they were basically about the same, a TNF and a JAK inhibitor, would you have given a pass to all JAK inhibitors? My sense is that the FDA lumps them as a class and in fact didn't have quite the same requirements for safety studies for the other JAK inhibitors. So it's one of those circumstances where, because you have a result in hand, you've decided post hoc about what you think that result generalizes to. But I think if the trial had gone the other way, I wonder if people might have been lumpers and not splitters as they were here.
Yeah, so really, really important points, and we will get into more discussion after. Let's see what else the group said. So we'll go to the next slide. So again, the 213 respondents, about half from US, but 43 countries, which is just amazing to do this. So so basically this is how did the FDA warning, or sometimes it might have been for you EMEA or for someone else, your own health authority, but how did the FDA warning change your use of JAK inhibitors? And if you look here, overall, it was selective. So I think they're answering that they're being selective on whom they'll use, not that this is a JAK1 selective. I think they're meaning they're going to stratify. If you look here, and that's 60 some percent, 63%, a little bit less in the US only, interestingly, because it was an FDA US warning, but in the FDA, to remind people, is there wasn't very good access from reimbursement, as well as FDA warnings well before oral surveillance, where it was thought to be positioned a bit differently than in some countries where it could have been before oral surveillance on equal selection of all the various drugs that you had access to. Okay, less JAK. So interestingly, so how did the FDA warning change your use of JAK inhibitors? So a good solid 1 in 5 people overall said I'm using less JAKs, and a little bit higher, not quite one, around 1 in 4 people, or 27 point some percent on the US group. And then where do you position as a respondent your use of a JAK inhibitor? So interestingly, again, almost the same, not quite, but almost the same. So about half the people in the overall, as well as in the US, are saying after a first TNF inhibitor. After a non-TNF inhibitor was a good chunk of people, about a third responding, not quite the exact same numbers, but fairly close in the 2 pie charts. And what does this mean? This probably means after a second line advanced therapy, because many people do prescribe, not that they have to this way, but TNFs, then another MOA, and then maybe they're thinking of JAK. So that's a good amount of people. And then another group saying, well, it's even after my second TNF, which is 18%. And I use a JAK before a TNF. Nobody in the US, probably hard to get access in the US with reimbursement. But interestingly, 6% are saying I'm still using a JAK before TNF, or I'm using it now. So I assume it was still using, but we don't know what the proportion was before. I can tell you in Canada and in Australia, before oral surveillance, new use JAK inhibitor in rheumatoid arthritis was somewhere around 40% of new use scripts of advanced therapies. So it wasn't everyone, but it certainly wasn't 6%. So that number might have gone way down. So let's again open it up. And what do people think? John, what do you think about this?
I think it's very striking that so many people change their practice patterns. I mean, that's basically what we're looking from the first set of graphs. How many people did something different than what they were doing before? And we're looking at, more than 3/4 of the respondents said that they changed their practice patterns just based on the results of one trial. And that's really shocking. I can't think of another trial that has had such an impact on practice patterns than perhaps this particular.
And it impacts so soon after a trial, because we knew some of the results before oral surveillance, of course, was published, but usually going from an RCT, even if it's a landmark, into behavioral change is a long, long time usually.
Exactly.
Yeah. It might have been different if it was equal, and people that then access and other things would be, if it was not, if it stayed as a non-inferior, it was just not non-inferior, maybe good. I think that's a good take on it too. Jeff?
Yeah, I'm encouraged by this. So the darker blue on the left, that people are choosier, you're more selective about who you give them to. I think, honestly, from my own perspective, that made sense. It makes sense from the perspective of you read a trial, you read a study, and you think, who do these results apply to? And that's how I interpret that darker blue. I've become more selective because the trial results apply to certain kinds of patients, and that's what's changed my behavior, as opposed to the lighter blue that, may have more indiscriminately soured people on prescribing. And I personally would be in the darker blue group, but we can talk about that. And that said, I still find it interesting that on the rightmost panel, about half of people still are pretty comfortable using this, where you can still get it paid for after a single TNF inhibitor.
Yeah. So again, affecting behavior. I think safety might affect behavior of rheumatologists more than, say, if we've had lots of studies, not every drug class, but we've had classes of drugs where they've been superior to a TNF, maybe monotherapy, maybe combo, and it didn't pick up changing TNF as first line advanced therapy in many regions and jurisdictions in RA. So maybe a safety trial will change behavior more than an efficacy trial. I'm just speculating there. Who knows? Roy, are you contrary to what you've heard or anything else to add here?
Yeah, well, first of all, there were regulatory changes, and the regulatory changes really do change how people prescribe. And I think that's what you're seeing here. I would hope that the more selective is actually kind of what Jeff was talking about. There are certain patients, which we'll show you in a minute, who really are at greater risk. And whether it's a JAK or whether it's a TNF, it doesn't make any difference. So you really have to think about who's at risk. Right. And then if you think about that, you become more selective. So I would pick more selective, but for a special population.
Yeah. Okay. So again, you're the generalizability to the highest risk patients. So that's a great segue. And before I announce the segue, remember to please put questions in the chat or in Q&A because we'll have lots of time for them. So Roy, you can do this beautifully and succinctly in your sleep. So I'd love you to go over what you think are not just the main findings, but some of the, I think, the important take homes of oral surveillance.
Right. So I want to make 2 points before we begin. One was that oral surveillance did not have the proper control group, the proper control, which you couldn't have had for ethical reasons. The proper control group would have been patients who just treated with conventional synthetic, right? And then you could have seen what the difference was with TOFA versus the conventional synthetic, but you can't do that in this trial, and you couldn't have done it for 5 years just treating the conventional synthetic. The other point I want to make is there were no other mechanisms of action, right? Non-TNF biologics were not in this trial, right? So I don't make that mistake. This is a graph from the paper, and what it does show that tofacitinib did not meet the non-inferiority criteria that was set up by the FDA for this trial, and that there numerically were more events of MACE and malignancy with TOFA than the TNF, which was either etanercept or adalimumab. What's important about this is that these events also occurred with the TNF inhibitor. And I think that that's something that people need to think about, right? They also occurred with the TNF inhibitor, but numerically more with the JAK. And the other point is the number needed to harm. To harm is actually quite large. And when you think about the benefit, the number needed to help with JAK is actually pretty low. So if you take a look at the number needed to harm versus the number needed to benefit, the risk benefit still is in favor of a JAK in an individual patient. But what this shows is non-inferiority was not met. It doesn't mean that it doesn't mean that it was inferior to, just statistically speaking, but non-inferiority was not met. But let's go to the next slide, which I think is more important. Can we go to the next slide? While you're doing that, I will also show you that with respect to the MACE, that the confidence interval crossed 1 for the 5 milligram TID, 5 milligrams BID. And that's something that I think John was talking about before. And while we're still waiting for the next slide, I'll also tell you that in TRACK, the etanercept arm had a MACE rate that was about 1.7, and this was 0.7. If it was 1.7 for the TNF in this trial, tofacitinib would have been superior. But again, it's 2 different trials. But this is really what I think is the key point. It was it was a specific subpopulation, and it was with both tofacitinib and TNF. And what was it? It was current smoking, it was aspirin use, it was being at least age 65, male sex. Very importantly, disease activity, continued disease activity, as well as baseline cardiovascular risk were the most significant independent risk factors for MACE. And it occurred with both, as I'll show you in a couple of slides. With respect to VTE, it occurred with both as well, but what were the risk factors? And it was a history of VTE, which is the major risk factor, but also being overweight, corticosteroid use, male sex, being older, oral contraceptive or HRT use, history of hypertension, and disease activity, right? And then for malignancy for tofacitinib TNF, it was older age, smoking, the race, Geographic location, it was more in North America. Why, I don't know, but I think there was more smoking in the US. And the history of chronic lung disease, COPD or ILD. Those are the risk factors. Let's go to the next slide because it's actually I'll show you the data which substantiates this. Can I go to the next one? The next one is on MACE, and it shows that if you have if you had a previous MI or you have a high risk for an MI, then those are the patients who, as you can see here, if you take a look at the top part of the graph, it was the patients that had a history of coronary artery disease, and it was high to the TNF as well as the TOFA. And if you were high risk, that was also high. But if you had intermediate risk, or you had borderline risk, or you had low risk, the risk really, really decreased. But what's important here to me is it's that subpopulation, right? But it's not just the JAKs. There's not TOFA. It's also the TNF. Next. And the next is VTE. And here are the risk factors for VTE. It shows you what it is. But really, it's the history of VTE was really very, very high. I have the right-hand part of the slide because we have no idea why VTEs occur, why they've been labeled for the JAK. VTEs don't increase over time. The rate really stays the same all the way through. And if the JAK really was a cause of VTE, you'd expect that the patients who are on the JAK would keep going. The right-hand part of that second graph on the left shows patients that don't have a history of VTE, it's almost non-existent, right? But on the left-hand side shows that it's a TNF as well as TOFA. TOFA is always a little bit numerically more important. Next.
Roy, before we go on here, do we know, like, obviously the biggest risk of having a VTE in the general population is having had one, so that risk makes tons of sense. But do we know,
or having RA?
Yeah, well, RA is a risk too, but in anyone, your biggest risk of a clot is having had a clot, shockingly.
Right.
But do we know, irrespective of anticoag, or most of these people weren't on anticoag? Because I've never seen in the paper, maybe I've missed it, what proportion were on.
Yeah, there were not many patients on anticoagulants, if any. I don't remember seeing that. Yeah.
Okay, because DOAC might have been for AFib too.
Right.
Yeah.
So here's malignancy, and that's the one that Jeff talks about, because this actually, the confidence interval was just to the right of 1, right? But if you take a look at a current smoker, it occurred numerically more with the TOFA 5, but with the TNF, which is in the pink, you can see that even in the smokers, you had more malignancy. Why would you expect that you wouldn't have more malignancy in a smoker? I don't know why. And those confidence intervals crossed. Past smokers, the same, but never a smoker, it's lower. And greater than 65 or ever smoked, you can see what those numbers are. So the key here is, if you've never a smoker, you certainly have much lower risk. But there's still a risk with the TNF if you are, as well as with the JAK. And the next slide. And these are adverse events of interest, and I show this, and I know it's very difficult to see. It's almost impossible for me to see. But TOFA 5 milligrams is the first column, and the only thing that is the confidence interval that's over 1 is actually herpes zoster and adjudicated pulmonary embolism, but that was only for TOFA 10 milligrams BID. Everything else was statistically similar between the two. The last point I want to make is that, so I want to summarize it. So I think what oral surveillance showed was that there were patients at risk. If they were older, they had VTEs, if they were smokers, they had high cardiovascular risk, they were at risk. And it made no difference if they were on JAK or TNF, numerically more with the JAK than TNF. In another paper that we published a couple of months ago, which is a post hoc analysis of the adalimumab database, of the upadacitinib database, the exact same thing was found. It made no difference whether you were on upadacitinib or adalimumab or methotrexate, actually. If you had those risk factors and you were older and you had the cardiovascular risk, that's where the risk was increased, all right? Now, that was a post hoc analysis. It really wasn't, it's structured very differently than oral surveillance. But it is a reason why I think that the FDA and the EMA were correct when they talked about all JAKs, all right? And these are the risks that you have. What I'm not really surprised about is that the FDA didn't turn around and put the same risk factors into TNF. And that's what I have to say.
Very insightful take on it. So let's do a rapid fire on this. And this is where, I mean, we're here to discuss for learning. Obviously, it's not one interpretation is wrong or right. They are our interpretations. So maybe John, what would you say to Roy or to Roy and I, if I'm on Roy's take on this? Where do you think maybe the argument could fall, or your interpretation might be a little bit different?
Well, I think the main issue is, what's the differential risk between these two? We know that someone who has a VTE is more likely to have a VTE, no matter what they're on. But how does it shake out when we compare them together? And I think when we look at MIs, it looks like there's some differential risk, and especially when we look at cancer in the study. And granted, the numbers are low, the numbers for any individual cancer are low. But there does seem to be a differential risk here that does not favor tofacitinib in oral surveillance. And also recognizing that while the trial enhanced for cardiovascular risk factors, it did not for cancer risk factors. And in fact, the patients could not have had a prior malignancy in this particular trial. So I think that Roy's argument is good for MACE, maybe not so good for the cancer side of things. Understanding that it's hard to dig in enough because the numbers are low. Really understand that.
But John, the point I wanted to make was the malignancies occurred with the TNF when they had those risk factors. And I absolutely agree with you. There is a numerical difference between tofacitinib and all these, right? You have a choice. Patients been on methotrexate, they have an incomplete response. What do you go to? And you have a choice of a TNF or a JAK. I have no problem going to a TNF. They work, right? And you probably do reduce the risk slightly, right? So there's no reason not to do that. So I would agree with you 100%.
Okay. And also, I mean, I think we would have a different interpretation if, say, tofacitinib had numerically a higher event rate on one of the important outcomes, like primary and also important secondary, and then it wasn't on the rest, or it was only found like sometimes it was more favorable and other times not. It's interestingly eerily how consistent it is that each time TNF were numerically less events than TOFA. Whether we looked at VTE or malignancy or serious infections in the older age group, or the primary, one of the co-primary outcomes, of course, MACE events. So in honesty, I think I was a little bit surprised about the results, particularly malignancy, because I didn't expect that to happen looking at previous databases. So yeah, so I think we could say we can interpret this study in so many different ways. Then Jeff, what are you going to counterpoint or point as we discuss about this? What is your thinking here?
So I'm intrigued by the malignancy because, of course, for MACE, it wasn't non-inferior, but it also wasn't significantly increased. So you can decide how you feel about that. There was a numerically increased risk of MACE with TOFA compared to TNF, but there was a statistically significant difference for cancer. The thing, though, that I would remind people that sometimes gets a little bit lost, those cancer curves didn't diverge until about month 18 and beyond, meaning that the rates of cancer were basically spot on the same in both groups until you hit 1.5 years. Well, 1.5 years is kind of a long time. By that time, you've almost certainly decided, is this drug working well? Did it get my patient into remission? Like if she's feeling fantastically, she might feel a little bit different for you to say, okay, now you have to stop this medicine because now I'm worried about a small increase in cancer risk. If she's in remission and has 0 swollen and tender joints, that's probably a big deal to her, and there may be a lot of upside. So when I talked about this to patients and we kind of went through the pros and the cons, this is not like, oh, you definitely have an increased risk for cancer on day one. Assuming this is a real finding based on this trial's results, it looks like there's not that much separation until you're beyond a year into it.
Yeah, but I want to make a point. I want to make a point about that. So the risk of cancer was actually lung cancer, as you know, and that was actually the U.S., not the rest of the world. The U.S. was 25% of the population. So the rest of the world, it really was not different. But I think that what you say does make a little bit of sense. But again, it's the smokers. It was the smokers
who have a higher risk of cancer overall. I would be suspect if a curve diverged, Jeff, if biologically a drug such as a disease modifying type drug is affecting our risk of cancer. I'd be finding it suspect if the curves diverged at 2 months, because I'd say there isn't enough time. Even very carcinogenic things like asbestos, you don't get cancer 2 months after an exposure, right? So the fact that they diverged later on might in fact be true, that there is a plausibility, but I'll say that there's a biological thing happening, because I don't know what it's plausible. I just don't know what it is. So
I can tell you what it is. So tofacitinib does affect the natural killer cell, right? More so than the other JAKs. So that may be a reason why you see this, right? That may be the reason why you see this.
Yeah. So I think we're going to circle back to this, and I want to get your opinions on a couple other things. What about other diseases, and what about the other JAKs? But we do have some great questions. One is something that I won't be able to answer. So Dr. Barbosa is saying, after TNF inhibitor failure prior to using a JAK in the US, is it the economics of pushing the biosimilars, now that you have at least one approved in the US, and I probably 20 more to come very soon. But for the biosimilars, is it patient selection, avoiding the optics? Is it this real difference in MACE, or is it maybe things will change? I'll even change the question slightly. Maybe it'll change as you have generic JAKs, because we actually have generic JAKs in Canada, one JAK so far, of course, tofacitinib. Anyone want to try to shed light on what you think in the mind of the FDA, the requirement of using a JAK post TNF, or will it be post even more TNFs because biosimilars will be out economically, or what do you think?
Why would you use a TNF, biosimilar TNF, if a patient fails a TNF? Why would you do that?
I think some people were doing TNF to TNF in their answer. We had a proportion a bit higher in Europe, well, in the rest of the world than in US. But so you're saying, well, you'd go TNF to other MOA no matter what the other MOA, right? Is that what you're telling me?
Usually. I mean, it depends on whether you're a primary non-responder or a secondary non-responder. If you're a secondary non-responder, sure, you can go to another TNF. But if you're a primary non-responder, why would you go to a TNF? For cost? So you can use something cheap that doesn't work?
Well, your guidelines do suggest that you could, but it's not. It's the least durable option, going TNF to TNF in many RA patients. Durability is the second TNF.
That's another discussion, is about the legitimacy of the ACR guideline.
Yeah. We won't get it. Someone's going to talk about guidelines. Don't worry. And also on RheumNow, there's discussion of guidelines. Are they bogus or not? I don't mean bogus. I'm just saying guidelines. What's your interpretation? Okay. We got another question here that's come in. So looking at what do we know about biologically plausible mechanisms for the possible increased risk of MACE and cancer on tofacitinib patients from oral surveillance? So we've already had some chiming in about the natural killer cells. Any other biological plausible things that you've read about, or that you think people have bounced around?
Well,
no, that's disease activity. Sorry, go ahead, John.
Well, for MACE, there may be some biological plausibility that inhibiting TNF may be more stabilizing for plaques than maybe the IL-6 inhibition, perhaps, of a JAK inhibitor or other mechanisms. We do see differences in how patients respond in terms of cardiovascular risk factors, although that doesn't seem to be part of the mechanism here in terms of lipids going up with JAKs and IL-6 inhibitors, but not with TNF inhibitors to the same extent. So it's probably there may just be a biologically more protective effect of the TNF inhibitors on these people. They already have coronary disease. It's silent, and you don't stabilize the plaques as successfully with tofacitinib. There's some animal data about how tofacitinib affects the plaques in mice who are atherosclerosis prone. It does seem to have some protective effect in mice, and in some very, very small studies of looking at cardiac PET CT, for example, looking at what happens to the inflammation in plaques, it doesn't seem to change that inflammation very much, whereas we know that TNF inhibitors do that. So the question about why we see this could just be that TNF inhibitors are just better at protecting the atherosclerotic.
But I'm a little confused because the cardiovascular events occurred with a TNF in patients who were at risk or had an MI.
Well, they're not perfect.
And it wasn't that different.
Yeah, it's just like the COVID vaccine, right? Some people get COVID when they get a COVID vaccine, and some people on a TNF inhibitor are primed to have a cardiovascular event.
Well, that's a more major risk factor. All our risk factors, to remind everybody, are RA is obviously a risk factor, but it's not as major a risk factor as the traditional risk factors. And our drugs, some are risk factors like glucocorticoids and NSAIDs, some NSAIDs at least, and they're not major risk factors, they're minor risk factors. So the big risk factors should always be more common to have the events in high-risk people. Low-risk people have less events, but still can have events. High-risk people have more events. So I think Jeff wants to weigh in and ask you something, John, about INTRACT. But before he does, I'm going to say two things. The rate in the INTRACT trial, if tofacitinib had their rate and the INTRACT trial was on, they would have been highly protective, interestingly. Maybe in 10 years, we're so much better at treating lipids and stuff. That's one comment. But the other comment is there is no way in heck, but I could be wrong, but I'll be very emphatically wrong then. There's no way in heck that slightly changing lipids is going to have any effect on having a cardiovascular event unless if you have 100,000 people, it's going to have no increased event rate for a decade or two. The horizon of number needed to treat in a high-risk patient when you give a lipid lowering drug, you're protecting people 8, 10, 15 years out. So I don't believe the lipid mechanism has anything to do with anything other than somebody at the FDA that might be a lot smarter than me thought it had. Doesn't have any idea in my mind that it's doing anything perversely in the next 18 months to 5 years. But just my little point. So with that in mind, I think Jeff might be talking about INTRACT as well. So Jeff, what did you want to say about this?
Well, John, I wanted to comment on the other large RA cardiovascular safety study, the one that obviously you were so heavily involved in. So oral surveillance being second, but perhaps much more talked about for reasons that we're talking about it tonight. You know, there was no difference between tocilizumab and another TNF, etanercept. And of course, many people in oral surveillance got etanercept. But I wonder if you could speak to the event rates in INTRACT and then just think about how that relates to the underlying populations about who got in both those studies. You know, if the event rates of INTRACT were seen in the TNF inhibitors in oral surveillance, we wouldn't be having this conversation, or at least it would be a very different conversation. So I wonder if you could remind people what that showed and then speculate on how the patient selection that we started this conversation with might be informed by INTRACT.
Sure. I mean, it is very interesting that when you look on the surface at the inclusion and exclusion criteria for both trials, they're very, very similar. OnTract also over recruited patients who had cardiovascular risk factors, almost exactly the same entry criteria. But we did, these are events-driven trials, right? So you need to do these in populations where you're going to have events. If you do an events-driven trial in a population where you're not going to have any events, you're going to have to enroll a ton of people and follow them for a very long time. So economically for these trials, if you're going to accrue enough events to finish the trial, then you need to sample people who are going to have events. For OnTract, we oversampled in Eastern Europe very heavily. So it really was an effort to go to where people have events. And as you know, in Eastern Europe, Russia, especially back when, 10 years ago, men have heart attacks much earlier than the rest of the world. And so we specifically sampled there, and that's where a lot of the events were. In oral surveillance, most of the MI and cardiovascular events were in North America. So that's very different. So it just goes to show that your background population, your generalizable population, really depends on who you're sampling from. Does that change how we interpret this? It shouldn't when we're looking at the relative differences between the two. I mean, this is an instance where the relative risk is very important because the risk in OnTrack was so much higher, but yet the relative risks are different.
So, Jon, I want to make one comment about oral surveillance. So all these patients had at least one cardiovascular risk factor, right?
Yep.
Only about 20% were on statin.
True.
We're on
And
statin, yeah.
Only about 20% were on
Yeah.
statins.
Yep. And even
Right.
and even less. So even the people who had high cardiovascular risk or diabetes, only 40% of those patients were on statin. So they were not meeting what the minimum standard for being on a statin would be. And this is not specific to oral surveillance. This is what we see across the board in studies of RA, that high cardiovascular risk patients are not meeting the minimum standards that they should. And there was subgroup analysis that has not yet been published that suggested that the rates in the tofacitinib, at least the 5 milligram group, were very similar to the TNF group in the patients who were on statins already. So there didn't seem to be a differential effect in those patients who were potentially protected with statins.
An interesting thing is aspirin was a surrogate for having more cardiovascular outcomes, but aspirin, of course, we think reduces the rate of secondary prevention by about 40 to 50%. And so again, aspirin, I think, is just a window saying these are the higher risk patients. That's why they're on chronic aspirin, because aspirin's out in most countries for primary prevention, but it's in most countries because of various trials for secondary prevention. So it would be a surrogate, but in a lot of studies, the use of a statin is also a surrogate for having more events, even though overall it lowers an event rate, they're
Right.
higher risk patients. So was it seen that statin users, although of course they would have had events because they're properly treated, do we know as a sub-analysis on oral surveillance or on any of the other databases that have kind of tried to compare rates, that statin use is reducing cardiovascular events, or is a surrogate so it's actually increasing? They have a higher cardiovascular event rate.
Right. I think the fact that you are seeing a reduction in the statin users and not seeing that the statins are a marker for cardiovascular risk actually suggests that the actual effect could be even larger than we would expect. So I think that that's very promising for thinking about when I use it when I'm talking to my patients about how we can reduce their risk while they take a JAK inhibitor. Let's look at your overall cardiovascular risk. Do you have an indication for a statin, no matter whether you have RA or are using a JAK inhibitor or not? And if you do, then we have a lot of reason to apply it. And there's this indirect circumstantial evidence from oral surveillance to back that up.
Jon, I have a question for you. So did you just say that in a patient who has no risks, right, none of these risks that we've talked about, and you put them on a JAK, you would put them on a statin?
No, not necessarily. No.
Okay.
If they had an indication already for a statin, then it's even more reinforcement. And there's the other study with tofacitinib where the increase in lipids didn't happen in the people who were on the statin, and they had a reduction in CRP greater than what the tofa alone was able to do. So they have anti-inflammatory capabilities, and they're potentially cardioprotective in the people with an indication.
Yeah, so you're making a point that I make often, and that is if you have a patient who's at risk, no matter what you treat them with, you need to try and mitigate that risk as best as you can.
Including disease activity going down on whatever you're treating, avoiding steroids. I believe it. We all believe that. Yeah.
Yeah. So, go ahead.
Although that said, in the US, most rheumatologists are not terribly keen on themselves prescribing statins or other lipid-lowering therapies. So I guess keep that in mind, that although I completely agree with you, I think it will cause discomfort on the parts of rheumatologists to see themselves as being the primary people on the front line to do that. That said, I think there are strategies to make sure that it's clear somebody's responsible for it, because otherwise it may be that nobody's responsible for it.
Yeah, but yeah, I think you're 100% right. But in my practice, when I see a patient who has elevated lipids and is at risk, and I send him to the PCP, and the PCP does not do anything, I do it, because it's got to get, and someone's got to do it, and it's not that hard to do.
No, and you're already, most of these patients are methotrexate. You're already checking their liver function tests. You're already doing the things that you need to do. It's just a matter of writing the prescription.
So that brings up a comment, I think, to Jeff. Well, all of you here on the call have published widely on multimorbidity, comorbidity of our patients. Is it a bit of a travesty that we're not giving these people appropriate, not we as always prescribers, but recommending in our letters back to the primary care that we're not actually managing the comorbidities right? We meaning the physicians, the nurse practitioners, the people, the healthcare providers involved in their care. It would be true, I think, for their type 2 diabetes, their lipids, their blood pressure, things like that. Jeff, would you say that this is, we can do better? There's a gap here?
I definitely think as a healthcare system or team, we can and should be doing better. Whether rheumatologists see themselves as being the primary mediators of doing better for traditional cardiovascular risk factors, I think depends a lot on your bandwidth, whether there is a primary care doctor in the picture. I frankly will maybe not insist. I will just strongly urge to say, yes, I get that this is your only medical problem, but you are still well advantaged to having a primary care doctor in addition to me, your rheumatologist, because I think you get better care. You've got another provider that is part of his or her care team, and I think it is a good idea to have co-management and shared responsibility for some of these things.
Yeah. Yeah. And I think just for the audience, a good thing to think about in the GI doctors, the Crohn's docs that work around me, they have at the bottom of every note, remember your patient is at increased for them, it's Crohn's, they're talking about increased cardiovascular risk, and please do screening. And sometimes they'll even say, and treat like a type 2 diabetic. So in other words, change your targets to be a little bit tighter. So they're trying to remind people, and I think it's a good idea. And I always say, I'll stick it at the end of my note, and I don't routinely, but it probably should be. We have a couple questions have come in. So one thing is just a comment that people were choosing 2 TNFs before any other MOA because that's what they had access to in their country. That's how they prescribe, because it's not their choice, it's an access. So I understand where that could be coming from. So fair enough. And in the US, I think no one in the pie had said after 2 TNFs, and in the rest of the world, some people had, but a low percent. There's a couple questions, so I'm going to kind of change it a little bit to get the spirit of both the questions. So should we be screening for malignancy when we're looking at our patients who are smokers, men over a certain age? If so, how? I'm talking RA here. If so, how? So does anyone want to tackle, how do you screen? Should we screen? What do we do?
You're already supposed to screen for lung cancer in people who are smokers. It's a low dose CT every year for people
for 5 years or something, right?
Yeah, for people who have
20-year
pack year history of smoking. I think people are surprised that is a recommendation. It is, at least in the US. I don't know about Canada, but this is supposed to be a yearly screening. Now we're talking specifically about lung cancer and smokers. We're not talking about other malignancies, but this is the risk group that we see in oral surveillance. So I think if people just understand that you're not going out on a limb with that, with thinking about doing a CT scan to look for lung cancer in a smoker. And if there's something else that we can add on to that, I think the patient would be very, very reassured if they got a low dose CT scan, they're a smoker, and you're going to get ready to start tofacitinib. They would feel even more comfortable.
So are you going to do that come next week?
I've been doing it.
Okay, you've been doing it in the smokers over a certain age, or just any?
Anybody who meets the U.S. Preventive Task Force recommendation,
Right.
which is
Right.
45 to 75, who've had 20 years or more in the past, and that's past smokers, not just current smokers.
Okay, so CT, certainly those guidelines were actually based on cost effectiveness of number needed to detect and to treat a cancer, because treating early is better. I mean, we do have better drugs for lung cancer now, but picking up any cancer earlier is usually better. So I'm going to throw it out to the rest of the group. What about, should we be doing like Australia? They say they do a full skin exam once a year, or should we be doing obviously, I think everyone on listening as well would agree that all guidelines for colon cancer screening, pap test screening, breast mammogram, PSA is a bit controversial, so we won't go there for prostate, but that you should always follow your country guidelines. I think we'd all agree with that. But anything else? Skin screening, other screening?
Well, I've been telling myself for years that I need to remind patients on TNF inhibitors to get skin cancer checks, and I'm very, very remiss about doing it consistently. But it's a nagging issue for me that I don't do it more often. But we already have a precedent for doing that, and that's looking at for skin cancer in people on TNF inhibitors.
But on TNFs or on anything, methotrexate, any advanced therapy?
Most of the data is for TNF inhibitors. So
fair enough. Other thoughts on this?
Well, you sort of go ahead.
No, go ahead.
Well, you kind of made it implicit, Janet, but I think recommended population screening for your country is something that you should be attentive to for all your patients. Hard stop. So that's sort of mom and apple pie. Everybody would acknowledge that. That said, none of us remember to do the right thing when it comes to preventive health, every patient, every time, without exception. Like no doctor is that infallible. I think thinking about this in a team approach, anything you want to do systematically, you want to do it, every patient, every visit if possible. And in my mind, to engage office staff to help, make it part of check-in or medication reconciliation or whatever your procedure is when you have patients come in and do some initial things, but get the staff people involved as well to make sure that skin screening and mammography and colon cancer screening is done. And that way you're not reliant on the rheumatology provider to have to think of it explicitly every time. Get the whole healthcare team in your office involved.
In your office and the other healthcare team that has referred to you or whatever, that is part of the patient's care. Because I must say, I think it's lip service to say, oh, I'm going to do a full skin exam on every patient every year. Because even when I'm auscultating, which I like to do, heart and lungs on every visit, I'm not necessarily looking entirely at their body. In fact, I'm not usually, but I try to warn people of unhealing sores, things like that. The biggest risk of skin cancer is having skin cancer. So if you've had one, you need to be watched. Certain cancers are more worrisome. And we find AKs every single day. There's we have a lot of farmers around here, people that have been having RA for 30, 40, 50 years. But even if they didn't have RA, they've been out in the sun, et cetera. So I think skin cancer information is good for the general population, especially as they get older, and especially, certain skin types or past cancers because they're at higher risk. So I like these ideas. I just can honestly say that I'm not going to gown a person on every year explicitly for looking for skin cancer. So I can tell you right here, I don't do it all the time. Couple things I'd like to ask, what % of your population that you see with RA in your practice do you think oral surveillance is generalizable to? So you might be generalizing to the people who have had events. So Roy, what % of your practice would be not just an inclusion criteria for the oral surveillance, but the higher risk people, do you think?
Yeah, so I think the higher risk is probably, I'm guessing, but somewhere between 10 and 20%. I think that is the higher risk, maybe a little bit higher.
Okay, and you would have a mature practice probably like I do. I'm still seeing news. You're probably still seeing news, but a lot of my patients, the median disease duration in my practice is about 10 to 12 years of RA, even though I obviously see longer and I see early. So, John, what do you think in your practice?
Well, I think if we look at except that the highest risk people for MACE were the people who have known coronary disease. That would be a pretty small group. If we're thinking about over 65 former smokers, that's a much, much larger group. And I don't know if I want to restrict it just to people who have coronary disease to think about people's risk, obviously, but but it would be a much, much smaller group if it's just people who I know have coronary disease, less than 5%. But then there's a lot of people who have coronary disease that I don't know about. So I'd say that about 20 to 25%, as high as a third, could fit oral surveillance criteria. And then if you add men in, that's even more. And then if we put in cancer risk factors, if we put in VTE risk factors, and we amalgamate all those things, then you're getting into a pretty big group of people.
Interesting. At least you think that would have met criteria for any of these being high risk.
Right, for any of the, and then we think about zoster risk and all these things that skew
Fair
more
enough.
towards the TNF inhibitor than the JAK inhibitor, especially early on in use, then we're getting into a pretty sizable chunk of people.
So we have a bit of variation here. So I think part of what you're saying too, I'm going to interpret it this way. You didn't really say it this way, but it's a lifelong risk. All our patients, the majority are going to have cardiovascular events like kill them, or cancers. Like that would be the two most common causes of death in many countries that are listening to this. So if you look at lifelong risk, but if I look at a small horizon risk, I guess it's the incident rate is quite low, but the cumulative prevalence over their lifetime to death is not so low, maybe.
Especially if you're thinking about the number needed to harm. What's the number needed to harm for anything to happen to me at any point when I'm on this drug? That includes, having really bad zoster too. I mean, that's
right. But the number needed to help is very low on all our advanced therapies. We have a number needed to help people for whether we say, the lowest cut point of an ACR 20, that would be 1 and 2. It's more than 1 and 2, but 1 and 2 in a clinical practice, probably. Most drugs aren't treating 50% of patients effective, like I won't call it fully effectively, but somewhat effectively, because an ACR 20 is a 50% reduction in joint counts usually, and when they look at the data. So 50% reduction in joint counts, 50% of patients on any advanced therapy, that's not so bad.
Yes, it is.
Right?
Yes, it is. Because even 50% reduction and you still have a lot of disease activity, that's really problematic when we're talking about VTEs, when we're talking about MIs, when we're talking about malignancy. So 50% reduction is really not good enough.
No, but I mean, it's not bad compared to when I treat blood hypertension. If I'm going to have to be the one treating it, I have to treat a lot of people to prevent one event down the road, but that's a different thing. I'm not helping them. I'm just preventing something later. We're helping our patients feel better, which is important, and be better, decreasing the risk. Can I do a couple yes, no's quickly? You can do yes, no, or maybe. Okay, so are you generalizing this to all JAKs? Let's start.
Absolutely.
Jeff. Okay,
absolutely.
Roy, absolutely.
Absolutely.
Jeff?
That is the data. That is the data. That's the reason why the EMA changed what they did. They looked at all the data from all the drugs, including vagotinib, and that's the reason why they changed. The FDA looked at all the data. It's all the drugs. When someone tells me, well, I'm going to use your upadacitinib because it's a JAK1, it's safer, that's baloney, right? They all have the same risk.
Okay, Jeff?
Yes, I'm a lumper when it comes to MOA about this topic.
Okay, John?
Same. When I get information otherwise, especially when you're talking about safety, you err on being careful with safety. And I think we have to err on being careful with safety.
And I'm going to say I don't really know, but it is applying to all drugs, all the class of JAK inhibitors. So I agree that labels say what they say. And people are asking, well, what about a TYK2? What about a TYK2? Anybody say yay, no, don't know? Well, it's not going to be used. There might be a JAK1 TYK2 in RA, but RA is not going to have a TYK2 in it.
TYK2 has the TYK2 deucravacitinib has a totally different safety profile, and it does, but it's not going to be used in RA. And again, you don't have all the data. You really don't have all the data with TYK2, but so far it seems that it is different.
It looks different to me too. That's my interpretation, but who knows? We don't have large RA trials and won't. There might be the JAK1 TYK2 drugs. We'll see what happens to them.
But I've looked at the laboratory safety, right? Laboratory safety
it doesn't have a safety
in lupus and in PSA.
Yeah.
We published it actually.
Yeah.
And it really is safer than the other JAKs. You know, we're going to end soon, but I really think that we really need to make the point. Don't get into don't make the mistake that this is just TOFA. It's not. Also, don't get into the mistake that if a patient fails a TNF, you wouldn't use a JAK. I certainly would use a JAK in that situation. They are very effective drugs, and you want to get the disease activity under control. So I don't use it last, but I would use it. I certainly would use it second to the US.
Okay. So we're lumping, not splitting. We're saying though TYK2 is different. That's important. We've looked at the range of who we think would be high-risk people, and high-risk people might be inclusion criteria or actual the highest risk who had events. We've talked about lumping and putting a whole bunch of events together for the risk or benefit, I think, for any drug that we're using in rheumatology. So I think this has actually given me some more insights. We've had great questions from the audience. So a couple of things, please go to RheumNow, at RheumNow, and look at what's happening with our Tuesday Night Rheum for next week. Also the hard decisions in RA. There's a lot of blogs and other things up there. There will be podcasts as well. So I think that really the next thing you need to know is next Tuesday we'll be talking about early RA, prevention, treatment, remission, a lot of great stuff. So we welcome you all to join next week. And as I say, thank you for the panelists. Thanks for Jack Cush and the wonderful team behind him that helps make these events occur. And I want everyone to have a good evening or wherever you are and the good rest of the day. Thank you.